Welcome, everyone, to Tips and Tools. I'm Dr. Carlos, behavioral psychologist, and my co-host,
Dr. G. Welcome to Tips and Tools. I'm a clinical psychologist, and first and foremost, I want to thank our sponsor, Elite Care Treatment, and would like to get our viewers' attention to their website, elitecaretreatment.com, and their phone number, 888-511-0607. If you have any questions regarding addiction and helping one of your loved ones, they're available 24/7.
Excellent. Well, we have a fun series coming up now.
Yeah,
we did a great series last time on addiction, covered the family and all the different symptoms we can find in addicts. But now we're going to really get into the nuts and bolts. We're going to get really specific. And I know in the next upcoming weeks, we're going to look at drugs.
Yes.
And today we're going to do an introduction,
Yeah.
Looking into the categories of drugs.
Absolutely.
I think a lot of stuff you're going to find out today is going to surprise you. You're going to learn a lot just like I did. Well, Dr. G, should we get started?
Let's get started.
All right, we got some fun ones here to learn about today. I know there's several categories of drugs.
Yes.
I think we talked about it before. Narcotics, anxiolytics, such and such, and we're going to get to 5 of the main ones. So tell us a little bit about narcotics.
Okay. So basically, before even we go into narcotics, let's just kind of articulate those general categories. We have narcotics, which are at times also known as analgesic, because they're basically more or less pain killers, if you will, and their main function is to induce sleep. So narcotic, the word itself, indicates that the main effect of the drug is to help a person to kind of almost fall asleep or induce sleep in a person. And it also can act against a painful experience in the body when we are really sleepy, if you will, groggy and sleepy and just got knocked out, then we don't feel the pain, right?
Gotcha.
So that's kind of the main action and effect of narcotics. Then we have anxiolytics, and they are more or less anti-anxiety medication that would help with reducing worries and anxiety in a person, agitation and anxiety. We have depressants, generally, that really just kind of work like anxiolytics, if you will, and they help a person to really reduce their general energy and anxiety, and ultimately they get depressed. They're depressants. Then we have stimulants, which would be the opposite of depressants. So they would help a person stimulate their mood and get more energetic, more not necessarily anxious, even though that's going to follow. If they use too much of stimulants, then ultimately they become very anxious. And but generally they're there to help a person to gain energy and stimulate a person. And we also have hallucinogens, which are generally there, which really has no major use, except for more recent studies have shown that they can actually help in therapeutic settings.
Really?
With experiences of trauma, helping with PTSD, helping with reduction of actual registration of memories of trauma. There's a lot of great studies that are coming out, and it's also controversial, very controversial, because of the history that they have had in the past when hallucinogens were used in experimental studies. We will get into that, but
I can't wait for that show. It's going to be interesting.
Yes, and hallucinogens, however, generally don't have good effects. I mean, if it is not in a controlled therapeutic environment, they can easily get out of hand, and we will talk about it more in depth, but they would cause hallucinations. They would cause hallucinations.
Like mushrooms, I think we mentioned.
Mushrooms, etc. So, and then we have, so these are more of the addictive categories where, of drugs that people can actually get addicted to, right? But then we also have more or less, if you will, as part of psychotropic medications that are prescribed to people with mental illness. We have antidepressants, so those are more non-addictive categories, antidepressants and antipsychotic or neuroleptic. They call them neuroleptic or antipsychotic.
Those are taking away like hallucinations and delusions.
The neuroleptic and antipsychotic, they would take away the delusions and hallucinations, but also they have major side effects because they're really working on the brain structure, so they can easily cause what we call extrapyramidal effects or symptoms, which we will get into later on. These are lifelong, very long-lasting adverse symptoms like muscle twitching and rigidity, etc. But and then antidepressants are also generally non-addictive, and they're prescribed for people who have depression. So those are the major categories. And now let's go back to narcotics. So the first category that you talked about, narcotics include mostly these, let's say the famous one of them are the opiates. Opiates include opium itself, which occurs naturally in the environment. Poppy seed, poppy flower, poppy seeds themselves, not the flower itself, but the seeds. They can be harnessed to create opium or produce opium. And then opium can be synthesized more or less into other versions, such as morphine and heroin, and even heroin itself can be further synthesized into different types of, kind of subsets, if you will. One of them that is being prescribed for pain medication, very well known as OxyContin or oxycodone.
It's a popular one, yeah.
Or codeine, for instance. Codeine would be another version of it. Now, there are certain variants that we will talk about later on, maybe in another show when we are talking actually about the depth of the opiates. There are variants called methadone and Suboxone, naltrexone. These would be variants that actually act like heroin or opiates, but they are non-addictive or less addictive. We will talk about that later on.
In some way.
Modified, yes, chemically modified. So, and they're actually being used in treatment against opiates. Right? Because, and if it is again in a controlled environment and fashion, and they're also only available by prescription, then they could help a person almost taper off from actual heroin and morphine and opium use clinically by kind of substituting this highly addictive substance with less addictive substance that acts similarly, because all these products that I just mentioned, they impact the dopamine receptors, mainly the dopamine receptors, also other types of receptors, but mostly and mainly the dopamine receptors in different ways.
I was going to ask you, are we going to get into neurotransmitters as
We
get
will
deeper
get into
these?
that too. We will get into that. Another show, I would say, because right now we want to keep an overview of all these categories. So let's just stick with the general understanding that narcotics / analgesics that are designed, or not necessarily designed, but that have their main effect revolving around reducing pain and inducing sleep, they include opiates, right? And the major series is opiates. And opiates generally include these mostly famous substances we talked about, which is opium, morphine, heroin, and variants.
Let me ask you this question, because it seems to me narcolepsy,
Yeah,
people just fall asleep.
right.
Same root word than narcotics.
Exactly.
So people tend to get sleepy on these?
Definitely. So on these and narcotics, people get groggy, people get sleepy. Generally, they put a person into they reduce the consciousness, if you will, of we kind of fall into almost like a sleep / awake mode. Depends on how much we're taking, and depends on the tolerance of the person, depends on the dose, depends on the metabolism, and depends on the pain. If someone just broke their leg and it is throbbing and you're pulling on it, well, there's only so much of morphine or heroin that can really knock them out. They could come out of it unless it's higher dose. They have less tolerance to these effects, and which could knock them out, which is generally also used in terms of surgery, if you will, narcotics are being used, and the variants of narcotics, like more high potency narcotics, are used to put a person asleep so that they can go through surgery where the
like
entire
anesthesia.
body, like anesthesia. They are high level and high grade narcotics where a person is completely asleep, they're completely unconscious, even through surgery. So the main effect, if you will, is sleep induction.
I just want to see if we can highlight some of the things I know we're going to discuss in the upcoming weeks. We're going to be talking about each category, the narcotics, anxiolytics, and all these different categories of drugs. We're going to be looking at symptoms. We're going to be looking at withdrawal, toxicity levels, even why people choose certain ones. What are they really trying to get out of it?
Very good.
We'll look at the political and economic ramifications as well. What's going on out there? The social environments. We're going to do an extensive look at all these, aren't we?
Absolutely, and also even now we can very briefly touch on the general idea of why a person would prefer narcotics to, let's say, anxiolytics, because not everybody likes to take morphine and heroin, etc. They may like to take something that we will talk about, like stimulants, right, or depressants. So there is a preference, certainly. And that preference we will get into much more deeply in terms of the neurotransmitters and receptors and how what we call pharmacokinetics and pharmacodynamics of the substances within the body are laid out. But just here right now, generally, people who tend to really kind of want to be knocked out, if you will, that kind of lose their conscious awareness toward themselves, internal stimuli as well as external stimuli, they would prefer narcotics because ultimately it knocks them out. They can get almost like a reprieve, maybe for a few minutes to a few hours or maybe a day or two, kind of be completely knocked out. Many people especially people who have had accidents and surgeries and maybe long-term disabilities that are painful, that's why they gravitate toward the narcotics, right? Because it just helps them to kind of remain asleep for most of their time during the day.
Absolutely.
So they don't feel pain. That would be the idea. A lot of individuals who are gravitating toward reduction of physical or even mental pain and get knocked out, remain more or less out of awareness of their pain and environment, they would prefer narcotics.
So the main theme is really they're trying, use of any of these five, you can see if I'm right on this or not. The main theme is I'm avoiding pain and seeking pleasure. Can we go as simplistic as Freud on that one?
Absolutely, because certainly the use of opiates gives a person pleasure. The dopamine receptors are fired up, the dopamine neurotransmitter is released, in excessive amount. Therefore, yes, there is a sense of pleasure that is associated with it, as well as reduced pain.
It does do the old
trick.
What did Freud used to call it? The hydraulic model, or
the catharsis? No, I see what you're saying.
Remember the hydraulic drive?
Yeah.
Well, got to go back to my textbooks and look at them.
Okay.
Anyway, so we're going to cover these five. I know we're also going to cover possibly gender differences and age differences. What I mean by that,
certainly
older patients in their 60s maybe don't have the liver functioning as well.
Absolutely. Yeah, we can definitely take a look at that, but that would require the specific show for each drug that we go to.
And then we're also maybe look at the prevalence in the sense, or not the prevalence, but the inclination for the gender. And what I mean by that is, do women prefer certain types of drugs?
Sure.
Do men prefer certain types of drugs?
Absolutely.
I know in the fitness profession, when I used to be there decades ago, stimulants were pretty popular among the trainers. They tended to use that a lot because it helped them with weight loss, like in cocaine.
Right.
So they were addicted to that, or meth actually was a big one for them too, because they were
Especially
able to.
for women too.
Exactly. Losing the weight, yeah.
And you can bring a lot of good information in terms of stats, from more or less the socioeconomic impact, political issues that are going around, let's say, controlling or curtailing or governing, like, for instance, the most recent subject about marijuana use.
Oh,
Right?
yeah.
Is it going to be available? How many states are going to come up with some rules to make it more accessible and available and commercialize the product?
That's going to be a great episode because I know we're going to get insight from you in regards to THC levels.
Okay.
Is it bad? Is it really good? Can it be used? A lot of people are still confused because you got two sides lobbying and trying to say their point of view slanted a certain way. And I want to look at the individual component, which we'll do with you especially. We'll look at the state. In other words, how does it affect the group as a collective? How does it affect society in general?
Wonderful.
And I also want to look at the, what would you call it, the country effect. How's it nationally?
Very good.
Because, countries like Afghanistan or other countries in the Middle East will use that as a moneymaker for them.
Oh, yeah.
Terrorist groups are funded
They
a lot.
fund it through, a lot of this.
So we'll be looking through a lot of the different aspects. It doesn't just permeate one person. It permeates the whole entire society.
Families and there's also the medicinal use, how the medicinal use
That's good.
is kind of regulated and governed. So the next category we can look at is anxiolytics, and that is, as we mentioned, and as the word itself says, anxiolytics, more or less anti-anxiety medication. So as part of that, again, we have kind of subcategories such as barbiturates, which is the older, more traditional, more older, archaic category because they're highly addictive.
Do they even make them?
Highly addictive. They make them, but they're still available, but they're only used in only very specific cases and reasons, such as, let's say, during detox. In certain detox centers, they can use that. And again, in hospital settings, when people are come out of surgeries or go into surgeries and things like that.
They're being monitored very closely.
Very, very close monitoring. So barbiturates are the kind of the old category, the old style. But the next generation after that were benzodiazepines, and benzos are also addictive, although not as highly addictive as barbiturates and dangerous. So they're less addictive, less dangerous, but still quite addictive for the general population, so the non-hospital population who is, maybe, and a lot of people really go to their doctors with that intent because they are worried, they are anxious in their lives, at times even for panic attacks that occur to a person. They may go to the doctor and say, "Doc, listen, sometimes it's for social phobia, sometimes for public speaking, or in general anxiety, generalized anxiety disorder, for instance." So the core issue is heightened anxiety. If a person finds themselves highly anxious in situations, whether it is specific or general situation, whether it is lifelong or after a certain event, just most recently, when people are highly anxious, agitated, frustrated, and in fact, to the extent that they see accompanying symptoms, like physical symptoms, such as heart rate is going up, pulse, even blood pressure, blood flow that they sense, like for instance, flushing in their face or hands, or sweating. All those could be symptoms for a person to kind of register their own anxiety, notice their own anxiety, and also generally for people who, kind of have worries in their lives. Maybe they're financial worries or worries about their children or parents. Maybe there's some ailment going on, maybe some pending, contract or end of phase of a phase of life that is happening. So if they're quite worried and anxious about that, then they're prone to take anxiolytics, something that reduces the anxiety. Now, you can't easily get barbiturates, even as, part of street drugs, you can't really get barbiturates because they're highly, risky. But you could get benzos, and the other version of it that is easily available everywhere is alcohol. Alcohol itself is an anxiolytic. Now, the core issue or the core mechanics, if you will, or the impact on the body and the physiology of this drug is that it increases a neurotransmitter called GABA. GABA is a specific neurotransmitter that really reduces anxiety. So it helps that reduction of this felt sense of being worried and anxious. The more GABA we have, the less anxiety. So that's what these drugs do. They mainly increase the levels of GABA. Alcohol does that. Now, there are other neurotransmitters also that are activated and produced. We will talk about them later on, but the main core element here is the concept of GABA. GABA is increased, anxiety is reduced, no matter which one of these we take, and each one of them certainly has a different, if you will, nature to it, both in terms of accessibility, availability, affordability, and whether or not you need prescription. Such as you don't need prescription for alcohol. I mean, if you're 21 years and older, I mean, that's not a prescription, but legally a permit, right? You don't generally, even people who are minors, they can easily access alcohol because it's probably in their parents' cupboard. Now, alcohol we regard as depressant. This is a tricky one. We will talk about it later on, why initially alcohol is known not as depressant, but as actually something that, increases the energy and mood, heightens the sense of pleasure and easygoing, attitude in a person. How come? If it is a depressant, because that's the paradoxical issue here. When you tell people alcohol is a depressant, it's mind-boggling to them. They're surprised. They say, "Are you sure? Can alcohol be a depressant? Isn't it?" I don't think so. When I drink alcohol, I feel better. I feel more relaxed. I feel more outgoing. I feel more talkative. I feel more easygoing. I feel like things are okay, and I have more, sometimes even more energy to do things, So that's why it's paradoxical. They don't really understand how come that alcohol is actually a depressant. But we will get into that later on in another show in terms of this paradoxical effect.
Should probably have one just on alcohol and marijuana.
Probably. And that is that second substance that you mentioned, which is part of the depressant category, marijuana. Marijuana too, by the way, again, people are kind of puzzled by this. They think, are you sure marijuana is a depressant? Because initially, that's the difference. I think the reason people are mixed up about this is because both alcohol and marijuana have a different initial impact than long-term use. Okay. Or long duration of use. Long-term use can be regarded in two different ways. Like for instance, you could drink alcohol for an hour or two. But what if you drink alcohol for 12 hours? Consume alcohol or alcoholic drinks. What if you consume alcoholic drinks for kind of constantly for 12 hours or 24 hours or 72 hours? Right? That's long-term use. Now, there is another version of long-term use, which is what if you are actually an alcoholic and have been consuming alcoholic drinks for 10 years, right, on a daily basis, more or less. Well, that's long-term use, a very long-term use. That we will not talk about it right now. But what I mentioned between initial and kind of delayed, let's call it delayed impact. So both of them, alcohol and marijuana, initially have a little bit of a different impact, which is usually associated with that sense of what we call disinhibition. They have this disinhibitory impact that, and again, anxiolytic impact. They reduce anxiety and disinhibition and inhibition. So as a result of that disinhibitory impact that they both have, initially people think and alcohol is an upper, right? It gets me up and running. It gets me happy. It gets me turns me into a likable person, more or less, right?
That's really common in the dating world, right? It gives me
Yeah.
the confidence to be able to ask that girl out.
Right.
And of course, we know the old story. The guy gives her a couple of drinks to make her more disinhibited.
Yes.
So it's kind of an interesting twist there.
Twist there.
Yeah.
But then what happens after a few hours of using marijuana or alcohol? Then really the long-term impact of the substance shows itself. Something that you didn't see in the beginning. What happens after that dating scene? There we go. People more or less crash.
Yeah.
That's why it is a depressant. It's actually a depressant in the right dose. Now, if you kept drinking alcohol, let's say, using marijuana in a controlled fashion, like you're just using it for half an hour, okay? And then that's it. You stop and you don't use it. Allow your body to recover from it. So you never fall into the depressant end of it, right? And then 2 days later, a week later, you use for half an hour or an hour, whether it is alcohol or smoke a joint or whatever, and then you stop using, and then you don't use it again for 2-3 days or a week or two, and then you use it again for an hour. Overall, over many weeks or months of doing this, you would never experience the depressant cycle of either of these.
Oh, really?
Right. And then you would think, oh, these are uppers. These are not depressants. Because you go back to your own original experience, which is very limited and structured in that way. But
Complicated.
that's very complicated. But generally,
Interesting.
People don't just drink alcohol for only a couple of hours. Unless, again, they're very disciplined. And we have maybe, 50% or more of the population is disciplined to occasionally drink alcohol, and they don't fall into the depressant cycle. Same thing with marijuana. If it is really just kind of dabbled into, probed once in a while, then people don't see the actual depressant cycle of it. But people who, let's say, are using marijuana really as medicinal remedy.
That's when it's usually the narcotic form?
Well,
like a narcotic, I guess?
Well, not necessarily. It can, and that's when you talk about some people being stoned. Not everybody has that experience, and being stoned is more being out of it, like as if you're asleep, because you're unresponsive. People who are stoned, they use marijuana, and they have a specific tolerance that has, kind of been taxed, and then they get into this spaced out state of mind. They're still breathing. They could respond to you, but it is, quite unintelligible. You don't know what they're talking about. They're in a kind of a different world or worldly experience. They're out of it.
That, yeah.
You have been accused of it?
I've been accused of that. Yes.
With or without marijuana?
Without, actually. It's amazing.
Without. That's dangerous.
Yes, that's amazing.
It's like
we'll talk about that in another special.
Without cause.
Without cause. WC on the diagnosis
You want me
sheet.
to take your temperature? No. Okay.
So we'll look at that as well, and we'll also talk a little bit about the political side of it.
You love to talk about political side. So
political junkie.
no matter what I do to get him
He tries to get away.
from... Okay, let's talk about political side.
Not today, but I mean, later on we'll talk a little bit about, because one of the questions everybody has, which hopefully you'll clear up, is it really bad for you? And some of the people who say it is bad for you is because the marijuana we use today is different than what we used 30 years ago. Other people say, no, it's fine if you do proper dosages. And we'll hopefully discuss that a little bit to clarify, because some people are wondering, should my child have it or not? I mean, Colorado, I think, is legal.
Yeah.
I've spoken to some individuals from Colorado in law enforcement, and they have one perspective, but they have a different type of perspective. They have a legal perspective.
Yeah.
So it's interesting. We'll also find out if it maybe affects people in poor socioeconomic environments more so.
Well, everyone, I think if you ask anyone who is quite educated and well-versed in like what we talked about, the pharmacodynamics, pharmacokinetics, impacts of, and the rate of metabolism, and then side effects, main effects, withdrawal effects, intoxication effects, if someone is really well versed into all this, and then also understands the underlying conditions that would require medication, that in certain cases, let's say psychotic presentations, depressive, very much depressive episodes, more or less known as clinical depression or major depression, or let's say panic attacks, or painful experience, or painful accidents and things like that. Anyone, like for instance, even cancer, that malignant cancers that are actually painful. If you talk to anyone who is really well educated, they would tell you that they're both good and bad.
That's what makes it complicated.
That's what makes it complicated. There's no black and white answer to this. That's all good or all bad. They're both good and bad. Depends on the situation, person, condition, diagnosis, dosage, tolerance, level of dependence, family, genetics. Depends on so many different factors.
Before we get to the other one, where we're not sure where we are in the world, and Alice in Wonderland drugs, I guess you can call them the hallucinogenics.
Yeah.
Before we get to that, where can we get more information? People need help if they know somebody who's got an issue addicted to drugs. Where do we go?
Well, I would recommend going to our sponsor's website, which is elitecaretreatment.com, and you can also call them at 888-511-0607. It's a great website that you can go to, a great company that deals with addiction.
Hi, welcome to Addictive. This is Addictive Recovery, and my name is Yvette Kuglin, and I'm part of the staff.
Addictive Recovery Center has helped people in dual diagnosis for 5 years. We accept most PPO insurances and provide luxury accommodations and 24-hour support. To speak with an admissions counselor, call 1-888-242-4450.
A lot of time we don't even know what's wrong with us, and sometimes we need to get away to figure that out. So if you want to go for a little retreat out in Corona Del Mar, which is a confidential location, we're here to help. So we're only a phone call away. Thank you.
We're going to be taking a good look at alcohol. We're looking at it has been used in the last century or two.
Absolutely.
People are using it as a painkiller.
Painkiller.
For tooth pain.
Uh-huh.
Or teeth. When they had pain with their teeth, they rubbed it on that for little children who were teething.
Right.
Remember stories, I've heard grandmas tell me stories that they used to give them a little whiskey or brandy on the gums when the kids were like 6 months old. Yeah. So it's fascinating.
Which is a myth, by the way, because it's really not, it doesn't have painkiller characteristics, right? But again, because in its extreme version, if you think of it as a spectrum, at the lower end of the spectrum, you have this anti-anxiety effect. But the more of this product you take, then it actually turns into what we call a depressant.
Yeah, we talked a little bit about that before.
Yes. And the more alcohol or benzos or barbiturates you take, it then also turns into an actual narcotic, because that too is sleep inducing.
So it transcends 3 categories.
It can transcend the 3 categories, because if you think about
Even
it,
hallucinogenics too, right? Or does it get to that point where you can actually start hallucinating stuff?
well, that would be more of a psychotic
break. What's that called?
Reaction, or psychotic break, or psychotic.
That wasn't Korsakoff.
Reaction. No, Wernicke-Korsakoff. No, that's different. Yeah. Well, Wernicke-Korsakoff is a syndrome that is related to prolonged alcohol use. We'll talk about that later. But that's the interesting part, because ultimately, like people who die of alcoholism outside of liver dysfunction, cirrhosis, generally most people who die, like let's say on the streets of alcoholism, they're known to really kind of die because of suffocation. They're drowning, because really more or less the lungs are filled with fluids, and also higher levels of this category of depressant ultimately depresses the functionality of breathing, right? So why is it called depressant? Because ultimately depressant's function depresses the physiological functioning of our organs. That's what they do, right?
I was going to ask you one question about the anxiolytics. Are we also going to look at when is it a good time to use them and when is it not? And what I mean by that is you were talking about public speaking, for instance, right? Some people get really nervous. Yeah. But some people may just take a pill when they could have just worked on it.
Right.
Whether or not maybe practicing in front of 3 or 4 people or just doing cognitive behavioral therapy, working on those thoughts, trying to change the thoughts. Right. Can we talk a little bit about what that threshold is when we cover that area?
Yeah, we can talk about the threshold as well. And also when it comes to, let's say, public speaking, when people take certain medication, that right there we can also distinguish between another category, anxiolytics, and something else that are called beta blockers. Beta blockers are anti-hypertensive drugs. So basically they bring down hypertension, which is another, if you will, version or form of agitation, right? But it's a physiological agitation. Heart rate, again, the symptoms are kind of similar. Heart rate goes up, blood pressure, pulse, etc. But it's more of a cellular, physiological phenomenon rather than a mental phenomenon, right? So that's when beta blockers can be very helpful because basically they calm down the body, not necessarily the mind, right? Like when they calm down the body, remember that anxiety or any emotion has to kind of be registered. Like feelings and emotions don't exist mentally. If you can't...
Oh, and that hurt my head. Go ahead.
Yeah,
repeat that again?
There is no mental there is mental representation of emotion, but there is no mental manifestation or tangible evidence, if you will, or tangible record.
Like the heart rate.
Well,
heart
mentally there is none.
Yeah.
Right? There's no heart rate in our mind. So therefore, in order to really record and register tangibly an emotion that we may call shame, guilt, fear, anxiety, worries, happiness, etc., you have to have an associated bodily experience. How can you feel happy if you don't feel it in your body? There is some symptom. There is some sign, more than symptom. In this case, we really talk about signs, more or less objective signs. Objective signs that there is something happening in you that can be recorded, more or less. There's a change of one state into another, and it can be recorded. It can be in terms of tactile sensation, right? So basically, skin conductance, that can be recorded. Electricity, sweating, blood flow, temperature, all of that can be recorded on our skin. Right. On top of that, there are other things: pupil dilation, changes in, again, heart rate. These are all physiological changes that occur that are associated at the exact same time with a certain feeling. So if a person is going in front of a public forum and they're right there standing up there and they report to you, oh, I feel anxious, I feel worried, I feel embarrassed, or I feel like I'm choking. A lot of times people say, I can't speak, I'm choking. That's again a sensation, a physiological sensation. What if they didn't have that? What if you stand up, you go up to the podium, and there is no sensation going on? Everything is fine. Everything is normal. There is no heightened blood pressure or heart rate or pulse. There's no sweating going on. There's no choking. There's no physical sensation. That is out of ordinary. Like you feel just as much, as good, as calm, as relaxed as when you were sitting in a chair an hour ago.
So it sounds like medication has a place at times.
Absolutely.
Because by reducing those symptoms physiologically, that would help the person
Right. So in this
cognitively and
case,
emotionally.
using beta blockers, we are kind of tricking the person.
Yeah.
We're tricking ourselves. We're tricking ourselves about the public speaking anxiety by circumventing the physiological symptoms and effects in the first place. So what happens is our mind tells ourselves there is nothing wrong. Everything is fine. And as a result, the mind then follows and delivers the job. It's not interrupted by all these stimuli that come from our body because we have calmed the body. So beta blockers have that type of effect because they're the antihypertensive.
It's funny, 'cause I was talking to a
Drugs.
psychiatrist today, and we were discussing the presidential debate that happened a couple nights ago.
Right.
And one of the candidates, I won't mention names, but you'll figure it out if you watch it. One of the candidates was very amped up. And I'm looking at him wondering, now that you're talking about the physiological reactions, I wonder if he had too many cups of coffee.
Yes.
And on top of that, maybe a little nervous about being on the stage in front of 15 million people.
Right.
Not knowing what the questions are going to be. I'm getting nervous just talking about it. I just can't imagine them going up there. And I'm wondering if you take 2 or 3 cups of coffee, that's really going to raise the level of anxiety, isn't it?
And that brings us to the next category.
Which is?
Stimulants.
Let's do it.
Right? Coffee. You said coffee.
That's right.
Caffeine basically is part of that category, stimulants. In addition to coffee, as part of the category of stimulants, we have cocaine. That's an example of stimulant. Methamphetamines, dextromethamphetamines, are different versions of amphetamines. Now, they have many names in the popular culture. We will get into the names and titles and monikers and this and that later on. But the category of stimulants, again, as it is distinguished from the other categories, is a category that has the main effect of energizing a person, of increasing the level of activity, of energy, focus, attention, motivation, the likelihood and propensity to follow through with a certain action, even though it may be very arduous. So for instance, with cocaine, a lot of people just use that in order to feel, that high that allows them to kind of feel energetic about something. Same thing, same category, by the way, applies to prescription medication that is given to people with ADHD, such as, let's say, Adderall, right?
That's right.
Ritalin, Adderall, and other stimulants. Now, sometimes the stimulants have also antidepressant effects, and there is a reason for that because, again, the stimulants are increasing dopamine, and again, dopamine itself has an antidepressant characteristic to it. Now, stimulants, what the stimulants do really is, they give a person this really false sense of energy. They think they last forever, but it doesn't. So, because the body is metabolizing the stimulants.
There's a heavy crash on that one, isn't there?
And there's a heavy crash unless you use again, right? So before there is a crash, and people who know that, they kind of prevent that crash by using again, right? So they're trying to keep themselves at a very heightened level of energy and stimulation, but that by itself is damaging and taxing to the body because it's like you're putting the body through a pressure cooker. That's what you're doing, right? You're infusing it with all these substances that what are they doing? They're increasing blood flow, heart rate. Sure, you as a kind of a side effect to that, your concentration changes. You can focus better. You're not as distracted. And you feel better generally, but better, better means hundreds of different things, but you feel better, meaning, again, in this case, you feel more energetic to do something. And it's usually, connected to actions for people who are, let's say, not ADHD, just general population who use stimulants. Is really linked to some kind of action as opposed to, let's say, narcotics. People who are taking narcotics, they don't want to take any action. They just want to relax. They want to just sleep, just be left alone. They like inaction versus people who take stimulants, coffee, like you said, people who go to work. A lot of people go to work morning, they take a lot of coffee, right? And they drink a lot of coffee. Energy drinks that have a lot of caffeine in them, right? And
those
vitamins.
are really popular these days too. I'll have to talk a little bit about
They've
those.
always been popular, right? The energy drinks. But yeah, so...
And I also want to talk a little bit, I know this is probably, some people who've caught it are probably a little perplexed.
Yeah.
And they're thinking, well, wait a minute, ADHD, that's a person who's kind of hyperactive already. Why are you going to give them a stimulant? And we'll tackle that as well, right?
Absolutely.
Because that is kind of sound like a counterintuitive.
Yeah, it does. That's paradoxical.
Yeah.
If they are all over the place or jumping up and down, why would you give them
more
of stimulant? They're stimulated enough, which is, in reality, they're not. This has an organic brain foundation to it. But yeah, so that would be the category of stimulant. And again, as you can see, I hope our viewers and listeners can really kind of visualize this differentiation between these categories. You know, people who don't want to take actions, they don't want to deal with things in life, they want to just go escape and into a different reality and be left alone. They're mostly prone to take narcotics or anxiolytics because they don't want to worry. Now, some who don't want to be knocked out and kind of fall asleep and rendered inactive, they don't like narcotics, right? So they would tend to gravitate toward anxiolytics, thinking that, okay, it just reduces my anxiety, but doesn't take away my functioning, right? But then the downside of that is if you take too much of these anxiolytics that then actually act as depressants, then you can also really become depressed, right? Both mind as well as body-wise. So then we talked about the other category in terms of stimulants. So that would be individuals who are gravitating toward, taking action, going to things, increasing their confidence, increasing their concentration and focus and attention to things. And again, energy, they love energy. That's what they're after. So they would go after stimulants. They wouldn't want narcotics or anxiolytics.
The final one's going to be the hallucinogenics, if I can say it. Yes.
Very good.
So we have a lot of them to cover here. A couple of them in a few minutes. What's going on here?
Well, there's a lot going on, as you know, with mushrooms.
Actually, before we do that,
psilocybin.
Some people that I have talked to don't understand sometimes the difference, or the distinction between what a hallucination is or what a delusion is. Can you quickly just define those two, and then we'll back to hallucinations?
Absolutely. So hallucinations are perceptions versus delusions that are beliefs. So that's one way to start kind of, creating two different tracks of thinking. When we are talking about hallucination, these are perceived stimuli that do not actually exist. That means objectively. If you got 5 people in the room and you ask them what objects they see in the room, more or less, objectively they should report the same thing. But let's say one person may just come up with something like a ghost or a vision or a certain another object that nobody else sees, and that would be like an external visual version of hallucination. Another hallucination can be auditory. So again, 5 people, 4 or 5 people may just say, the only sound they can hear in a certain room, let's say, is the music that is played by a certain radio. But then one person who is auditory hallucinating, they may, in addition to that or in lieu of that, may actually report something else completely different.
Maybe a relative who passed away.
It could be a relative passed away. It could be commands that they're receiving, like somebody talking to them or giving them commands.
The son of Sam killer.
And that would be the dangerous version of it, where you have a the person who has auditory command hallucinations
Now, he
to
had
hurt
both.
themselves or others.
He had both, didn't he? Because he had the
don't
hallucination. Son of Sam was the one that his dog was telling him to kill people, so he went out and killed him. If I remember correctly, I think it was the Son of Sam, but I'm not absolutely sure.
Okay.
It was in New York 30, 40 years ago, but he went out to kill people. So is that a combination of hallucination by listening to the dog talking to him?
That's a hallucination.
And then the delusion is him in this weird world.
Okay,
where he
well
goes,
that's the thing. They could also, in addition to hallucination, have delusions. But before we go to delusions, there are other types of hallucinations too. For instance, tactile, sensory hallucinations, where basically people feel animals or critters or basically
the ants thing.
ants or whatever creatures, more or less, crawling up their skin or face, tingling sensation, itchy sensation, so and this crawling sensation, that all their body is kind of almost sometimes even falling apart. That would be another hallucination. Like it's not falling apart, but they think it is falling apart.
My mom had that because she had a psychotic episode. And I remember that she had the same feeling. She thought spiders were crawling up her arm.
Spiders, yes.
Yeah.
So, and then you can have, also other types of hallucinations where you're actually focusing on organs. Like, so an organ of your body is really, let's say, falling apart or doing certain things that it's not really doing. That could be a hallucination if they actually feel like they're sensing it, feeling it, right? So, and then even taste or olfactory. Yeah, smelling something that is not there. That could be a hallucination as well. So the reason I'm bringing this up is because we want to focus on perception. What are they perceiving? What are they sensing subjectively? Or where another third party who is objectively observing can actually not attest to that. So that would be hallucination. Now, in addition to that, or separate from that, in lieu of that, people could have delusions. Now, delusions are just simply beliefs, and these are mostly known as erroneous beliefs or irrational beliefs, and they're extreme. An erroneous belief or irrational belief that's not extreme could be something like, I think I have failed in my life. And then you ask the person, well, why do you think I failed in my life? Because they say, well, I'm 35 and I don't have a job. Okay, that's kind of an irrational belief that just because you're 35 and you don't have a job, you're a failure.
But it's not a
in
delusion.
life. That's not a delusion. That's an irrational belief. That's an erroneous belief that can be worked through. But a delusion would be, again, something that only specifically exists for this person, and it is very egregious.
So I'm 35. I don't have a job because I insulted Nero, the emperor.
There you go.
That would be a delusion.
That would be a delusion. That is extreme. That's not everybody would be able to kind of relate to that. Nobody really. And it doesn't make sense. There's no basis for it. There's not even a probability for it if you think about it. So given the, let's say, the scientific instruments that we have, it's just impossible for us to really actually measure that. And it just doesn't make sense. It's almost an impossibility, right? Now, there are different versions of it. Now, for instance, the good example of it is people who may believe that they're followed by a government organization like FBI or CIA is after me. That can be true. Then it's not a delusion.
As we found out with the NSA tapping our phones, yeah.
It can be true. There's some suspects that I'm sure FBI is following, right? If they found out that they're being followed by FBI, then that's not a delusion. If they're actually being followed, right? Yeah. But how about the person who has really no ground? I mean, they don't have criminal background. There's nothing they have done in their lives to be important to FBI or CIA. And they believe, oh my God, FBI or CIA or NSA, whoever, aliens, UFOs, things like that, they're following me. They're persecuting me. They're after me. They have wiretapped my phone and video and TV and radio and everything, right? That becomes a delusion. It's a belief that's erroneous, irrational, extreme, unreal, simply unreal belief that has no basis, completely no basis. Now, some people go even beyond that. So in terms of their delusions, for instance, they may even believe, for instance, that my heart is talking to me. My liver is a person, or, has a history, and we have a communication between us. And that goes even further than just the general, extremeness of a delusion.
So we can talk more about that as well in regards to those mass killings in the schools.
Okay.
Some of those individuals, they thought that they could be resurrected.
Right.
They could be martyred.
Absolutely.
Because of that. So that could be an interesting conversation as well.
That could be very interesting. And then going back to the hallucinogens, and that's why they're called hallucinogens rather than, let's say, delusionogens or whatever, right? Because they don't cause delusions. They call hallucinations. So psilocybin or mushroom or what's that? Acid, right? And so basically, those are a lot of MDMA, ecstasy, and there are different subcategories of this general category. When they're taken, they can cause those perceptions, the erroneous perceptions that we talked about. People see things. They may, for instance, let's say, perceive their environment even moving around, like a stationary door to their bedroom may suddenly disappear in front of them or move, 2 feet ahead. And they would be kind of lost. Where did the door go, right? Or they may see people that they don't exist. They may see certain colors that they don't exist. They may hear certain things that, again, don't exist. Noises, voices, people talking, even stories that they conjure up. And all of that is due to the actual
It's going to be a
substance.
fascinating show on that one, too.
Yes.
So you were talking to me about earlier that some hallucinogenics are used for medicative purposes.
Yeah.
We'll talk more about that as well.
Yeah,
We're running out of time.
We are running out of time. Because we're running out of time, very quickly, there are 2 more categories that we mentioned in the beginning, antipsychotic and antidepressants. These are the less addictive or non-addictive, for the most part, non-addictive categories. The rest are addictive. Narcotics, depressants, anxiolytics, stimulants, hallucinogens, they're very highly addictive. But antipsychotic and antidepressants generally, again, for the most part, they're non-addictive. Antidepressants are have their own categories: SSRIs, NRIs, SNRIs, MAOIs. There are different subcategories of that. And then antipsychotic or neuroleptic, otherwise known as neuroleptics, they have also their like first generation, second generation, new generation, latest models that have come out. So we will talk about those, and they're generally used in a very controlled, prescribed fashion for specific disorders, as antidepressant already suggests, for clinical, highly debilitating type of a depression, and then antipsychotic or neuroleptic medication is usually used for, again, people who have psychoses, such as the ones that we mentioned, more like organic psychosis, such as hallucinations and delusions, and even behavioral. Sometimes it's because hallucinations and delusions are more, if you will, registered verbally and cognitively. These are cognitive, emotive, or cognitive affective realms of functioning, but also they're behavioral signs of psychosis. So we will talk about that.
We got so much. There's going to be fascinating shows coming out.
Very good.
I can't wait because we're going to be talking about narcotics, anxiolytics, depressants, stimulants, hallucinogens. We're going to take journeys through all different types of places. We're going to be looking at Afghanistan. What is that going to do with some of these drugs? We're going to be looking at that. Alice in Wonderland, how does she get involved in all this? We're going to find out about that too. We're going to look at Son of Sam. We're going to have a lot of things we're going to be looking at. Can't wait. Dr. G's got a lot of work to do, but I know he can do it. Thank you so much, Dr.
Thank
G.
you very much, Dr.
Fantastic
Carlos.
stuff.
Absolutely.
I hope you enjoyed it as well. Catch us for all our other shows, as we have several episodes now of Tips and Tools covering all sorts of things in addiction. And now upcoming in the next few weeks, we're going to be talking about medications, drugs. Take a look. Talk to you next time.